Hi everyone. Today we'll be discussing Horner syndrome. We'll be going over some of the pathophysiology and clinical presentations you might see in the clinic. What is Horner syndrome? It's also been called Bernard Horner syndrome and oculosympathetic palsy. It's a combination of the drooping eyelid, which is a ptosis, and constriction of the pupil, which is miosis. It is rare and affects the individual's eyes and face, and it's specifically related to the nervous system. It involves the sinking of one's eyeballs into the orbital cavity, which is the enophthalmos, and anisocoria, which is the unequal size of the pupils, constriction of the pupils, miosis, drooping eyelids, ptosis, and sweating or decreased sweating on the affected side, anhidrosis. It usually stems from another medical problem like strokes, tumors, or spinal cord injuries. In some cases, no underlying cause can be found. If you look at the picture on the left, you can see there is a ptosis on that person's left eye, which has the drooping eyelid, and also the miosis, which is a constricted pupil in the left eye compared to the right eye. The incidence in adults, the male to female ratio is usually 5 to 1, and it's equally distributed in all age groups in the general population. With pediatrics, it's estimated at 1.42 per 100,000 patients less than 19 years old. And at birth, it occurs in about 1 in 6,250 births. Prevalence, the likelihood of any disease causing a particular system does not strongly depend on the overall disease prevalence, but is affected by numerous other factors, including concurrent symptoms, patient details, etc. It was hard to find prevalence statistics for Horner syndrome, but it's likely that there's probably between 50 and 100,000 in the US with Horner syndrome if you kind of base it on the new incidence. The etiology, it varies with patient age and the site of the lesion. So 35 to 40% of cases have an unknown etiology, and Horner syndrome results in damage to a certain pathway of the sympathetic nervous system. Horner syndrome, which is acquired, is divided into 3 groups of neurons. The first order neuron, which they call central, second order neuron, which is preganglionic, and the third order neuron, postganglionic. It can also be congenital, and when you look at the hereditary causes of Horner's, it's an autosomal dominant trait. The first order neuron, which is a central neuron pathway that leads from the hypothalamus, it passes through the midbrain and extends into the upper portion of the spinal canal. And on the picture on the left, you can see it's in the bottom, the afferent neuron there, which is the first order neuron. Problems that can disrupt the nerve function of this region include things like strokes, tumors, diseases causing a loss of myelin sheath, neck trauma, cysts or cavities in the spinal column, which is serine gyomylia or gomylia. With the second order neurons, the preganglionic, this is the neuron path that extends from the spinal column across the upper part of the chest and into the side of the neck. So that's kind of in the middle of the picture there, but part of the CNS. Causes in this region related to nerve damage include lung cancer, which is also called Pancoast tumor. That's one of the more common tumors found with Horner syndrome. It can be a tumor of the myelin sheath, schwannoma. Damage to the aorta can also cause this. Surgery in the chest cavity and traumatic injury. If you look at the third order neuron, which is the postganglionic, the neuron path extends along the side of the neck. It leads to the facial skin and muscles of the iris and eyelids. Nerve damage within this region is usually associated with damage to the carotid artery along the side of the neck. damage to the jugular vein along the side of the neck, tumor or infection near the base of the skull, migraines, and cluster headaches. If you look at the etiology in children, it's usually injury to the neck or shoulders during delivery, a defect of the aorta present at birth, and tumors of the hormonal and nervous systems, like a neuroblastoma, which we've discussed in the past. The pathophys of Horner syndrome, it may develop from lesions at any point along the sympathetic pathway. Abnormalities found in all patients include mild to moderate ptosis, slight elevation of the lower lid, and upside down ptosis, and meiosis and dilation lag. Depending on the level of the lesion, impaired flushing and sweating can be ipsilateral. So in the first order neuron lesions, anhidrosis, or the lack of sweating, remember, affects the ipsilateral side of the body. Second order neuron lesions may cause anhidrosis of the ipsilateral face, and postganglionic lesions occur after vasomotor and pseudomotor fibers have branched off of the sympathetic chain. Anhidrosis is either absent or limited to an area above the ipsilateral brow, and the pupils react normally to light and accommodation. In congenital Horner syndrome, the iris heterochromia of the affected eye is usually hypopigmented as well. It occurs in children less than 2 years old. Iris heterochromia also may occur in long-standing Horner syndrome. So someone who's had Horner's their entire life may have a hypopigmented eye. If we look at our case study, I'll just kind of read through this and then we'll discuss this at the end when we actually arrive at our diagnosis. So some of the presenting symptoms and findings you might see in a person with Horner syndrome. We have Tim. He's a 26-year-old researcher for the use of medical marijuana. He denies alcohol and tobacco but does use marijuana recreationally. A family history includes a mother who had a stroke with no residual and a father suffers from familial hypercholesteremia. On physical exam, there's no unintentional weight loss or gain, a BMI of 25. Tim does have excessive fatigue. He developed pneumonia 4 months ago, and he has pain in the right upper arm and shoulder area, not related to injury. His skin, there is perspiration above and below the right eye. It's otherwise within normal limits. His head is within normal limits. Eyes, the right pupil does not constrict in response to light and is smaller in size compared to the left pupil, which constricts normally in response to light. Upon further examination, the practitioner notes that the right eyelid is slanted slightly downwards. His ears, nose, and sinuses were within normal limits. His mouth and throat, he does have hoarseness of his voice. With his neck, the right side of the neck is slightly enlarged. In his respiratory system, he has a non-productive cough for 1 month, but denies shortness of breath, and the lung sounds are clear. Some of the physical exam findings. The anisocoria, which is the unequal pupil size. Although this exists normally in 5% of the population, you can consider central nervous system disease with anisocoria. In this picture, you can see the pupils are clearly unequal, but this girl here does not have ptosis of the eye, which leads you to think anisocoria versus Horner syndrome. You'll also see meiosis, which is constricted and fixed pupils, like in the picture above the anisocoria. Those were different sizes. Meiosis is just constriction of the pupils, and it occurs with the use of pilocarpine drops for glaucoma treatment, the use of narcotics with iritis, and with brain damage of the pons. So in this picture, you look at this person, you say they do have meiosis, but both pupils are the same size in this picture, and there's no evident ptosis. So you wouldn't think this person would have Horner syndrome either. With cranial nerve 3 damage, also called third nerve palsy, you have unilateral dilated pupil with no reaction to light or accommodation, and occurs with oculomotor nerve damage. May also have a ptosis with eye deviating down and laterally. In this picture, with the cranial nerve 3 damage, you can see this person has a ptosis of the right eye, and their eye is slightly deviated to the right compared to their left. But you also have to consider that their pupils are equal in size in this picture here. So you wouldn't necessarily immediately arrive at a diagnosis of Horner syndrome with this person either. In Horner syndrome, you're going to see the unilateral small regular pupil does not react to light, or does react to light and accommodation. It occurs with Horner syndrome, a lesion of the sympathetic nerve. Also, you have to note the ptosis and absence of sweat on the same side. So you're going to see an anhidrosis typically if this is a first or second order neuronal lesion. Also, you note the ptosis of the left eye and the meiosis of the left eye. If we look at a few differential diagnoses with pain, the presence of pain merits a special consideration. You can consider axial shoulder, scapula, arm, or hand pain may be indicative of compression by an apical lung tumor or Pancoast tumor. It's usually acute onset. The ipsilateral facial or nerve pain may indicate carotid artery dissection, which may be caused by cardiovascular disease, arteriopathy, or trauma. Carotid artery dissection is suspected especially if there are signs or symptoms of retinal ischemia. Urgent neuroimaging studies should be obtained along with neurologic consultation. If we look at the differential diagnosis with a headache, there can be a cluster headache. It may develop ipsilateral Horner syndrome during an acute attack. The ipsilateral headache, it may be spontaneous carotid artery dissection or Horner syndrome. If you look at the differential diagnosis with nerve pain, you have the Rader paratrigeminal syndrome, usually middle-aged males who have Horner syndrome, and daily unilateral head pain. Pain is trigeminal pain associated with hypoesthesia or anesthesia in the distribution of the trigeminal nerve. Pain can be distinguished from cluster headaches or carotid artery disease in that the conditions occur without impairment of the trigeminal nerve function. Horner syndrome may be the first manifestation of neuroblastoma. If we look at differential diagnosis with the eyes, the Holmes 80 pupil neurological, which is a neurological disorder affecting the pupil and the autonomic nervous system. One pupil is larger than normal and constricts slowly, along with the absence of deep tendon reflexes of usually the Achilles tendon. Overall, this is a benign process. In anisocoria, the difference in pupil sizes between the eyes is normal in 20% of the adults. So to differentiate if Horner's or just anisocoria, consideration is made of when it's first noted. So whether it's more noticeable in a bright or dim illumination and whether or not there was a preceding event that could be related to that. In Argyll-Robertson pupil, it's a hallmark of tertiary neurosyphilis. Pupils will not constrict to light, but they will constrict with accommodation. The differential diagnosis with the eyes, just a couple more things. The iris sphincter muscle damage, you want to consider possible trauma. You have senile meiosis, which is a reduction in the pupil size due to age, and third nerve palsy, which is a complete causes a complete and totally closed eyelid. The eye cannot move inward or up, and the pupil is dilated with no reaction to light. Let's see, that's caused by head injury, infections, migraines, brain tumors, aneurysms, diabetes, and high blood pressure. If we look at a differential diagnosis with some drugs, they're the unilateral use of miotic drugs, drugs that constrict the pupil, anticholinesterase drugs, phenostigmine, neostigmine, ecothiophyte, and demicarium, parasympathomimetic drugs, pilocarpine, and carbachol. Unilateral use of mydriatic drugs are drugs that dilate the pupil, the sympathetic agonists, phenylephrine, and parasympathetic antagonists, which are like atropine. If we look at the lab and diagnostic testing, lab work does not usually play a significant role in the diagnosis. You can get a complete blood count, the FTA-ABS, VDRL tests, the purified protein derivative placements, and urine tests. And that's mostly just to rule out like neuroblastoma and other conditions. Other imaging tests might include a chest x-ray, so you'd be looking for apical bronchogenic carcinoma or the Pancoast tumors. CT of the head, you can look for possible strokes. MRI or MRI of the brain and neck, if it's painful, you can look for the carotid artery dissection. And the ultrasound of the neck, it's usually not reliable, but looks for carotid artery dissection. These are more of the important tests here. They have a topical cocaine test where you get topical dilation with Horner syndrome. It's hard to get a hold of the cocaine. The most common test to diagnose Horner syndrome, once you're convinced that it is Horner syndrome, is the topical aproclonidine or iopidine test. It's a practical and reliable alternative to the topical cocaine test. It has little to no effect on a normal pupil, but has a mydriatic effect on the abnormal pupil. So let me talk to you about the topical aproclonidine test. The topical aproclonidine test is a practical and reliable alternative to the topical cocaine test. It's readily available and adequately sensitive, 87%, and is currently the test of choice. Aproclonidine is an ocular hypotensive agent that acts as a weak alpha-1 agonist and a strong alpha-2 agonist. Typically given in a 0.5 or 1% solution, it has little to no effect on a normal pupil, but has the mydriatic effect on the abnormal pupil. In Horner syndrome, upregulation of alpha-1 receptors increases aproclonidine sensitivity and causes denervation supersensitivity of the iris dilator muscle. The denervation supersensitivity results in pupillary dilation and lid elevation on the abnormal side, but no response or mild miosis on the normal side from alpha-2 activity after aproclonidine administration. Reversal of anisocoria occurs after bilateral instillation of aproclonidine. In acute cases, false negative test results may occur because the alpha-1 receptor upregulation, on which the effect of aproclonidine depends, may take 5 to 8 days. Aproclonidine 0.5 or 1% may cause lethargy, bradycardia, and respiratory depression in infants younger than 6 months as a consequence of the immaturity of the blood-brain barrier. So in order to arrive at a diagnosis, if we go back and we look at the presenting symptoms and findings, we have Tim, the 26-year-old researcher for the use of medical marijuana. He has developed pneumonia 4 months ago. So what does that tell us? He already has Horner syndrome. He's presenting with Horner syndrome. We just need to confirm Horner's is actually our diagnosis. From the pneumonia that he had, we're probably going to consider a chest x-ray. In that chest x-ray, we may find a Pancoast tumor. Okay, a Pancoast tumor is also called a pulmonary sulcus tumor or a superior sulcus tumor. It's a tumor of the pulmonary apex. It is a type of lung cancer defined primarily by its location situated at the top end of either the right or left lung. It typically spreads to nearby tissues such as the ribs and vertebrae. Most Pancoast tumors are non-small cell cancers. The growing tumor can cause compression of a brachiocephalic vein, subclavian artery, phrenic nerve, recurrent laryngeal nerve, vagus nerve, or characteristically, compression of a sympathetic ganglion, resulting in a range of symptoms known as Horner syndrome. So Pancoast tumors were named for Henry Pancoast, a U.S. radiologist who described them in 1924 and again in 1932. So Pancoast tumors can include a complete Horner syndrome in severe cases, which include the meiosis, which is a constriction of the pupils, anhidrosis, which is lack of sweating, and ptosis, which is drooping of the eyelid, and enophthalmos, which is a sunken eyeball. So if we look at Tim's eyes, the right pupil does not constrict in response to light and is smaller in size compared to the left pupil. So you see the nisocoria. Upon further examination, the practitioner notes that the right eyelid is slanted slightly downwards, which is a ptosis. So from this, if we get a chest x-ray of him, which is kind of where we were going with this, we would find that Tim has a Pancoast tumor in the apex of his lungs. Subsequently, it is a second order neuron lesion, and we're able to establish that he does in fact have Horner syndrome from this Pancoast tumor. The mnemonic to remember is Pam is horny. Okay, so P is in ptosis, A is anhidrosis, and M is in meiosis. Pam is horny. And you can conclude that in our case study, Tim has Horner's. So I hope you enjoyed our presentation, kind of walking you through how to diagnose Horner syndrome, kind of the clinical presentation you might see, some of the different ways this sympathetic nervous system is involved in Horner syndrome with the first, second, and third order neurons. And have a good day.